Hey, this is Gautam Malhotra. I am a physician in the was a physician in the VA New Jersey healthcare system, clinical professor at Rutgers. This is part 2 of my Introduction to Nerve Conduction Studies assemblage of slides. It's a different way of approaching it. Instead of talking to you about topics, I've kind of merged everything and tried to put it in the form of a case. So this is the motor case. If you haven't seen part 1, if you haven't seen the sensory stuff, that's what you should do first. Don't watch this. So in the last talk, I clarified electrodiagnostic testing contextually and how important the differential diagnosis is for the encounter. We clinically assessed a sensory complaint, discussed the anatomy of the sensory peripheral nervous system, clarified how stimulation occurs and how action potentials are propagated. We talked about the electrodes and how they conveyed the signals through the differential amplifier, filters, and displays. We talked about sensory nerve action potentials. One second. Troubleshooting them, especially with stimulus artifact. And EMG really played no role. Finally, we designed a report. So if you didn't see that, I really recommend you go and see that. As a reminder, electrodiagnosis is the use of equipment to display alterations in nerve and muscle discharges so that we can apply it clinically. Just to remind you, the benefits are many, including confirming and addressing clinical suspicions and guiding next steps in testing and management. For this talk, I want to focus on the neuromuscular complaints of weakness and atrophy. Since we're talking about weakness, I just want to digress for a moment and acknowledge that now that you're all physiatrists, weakness means something completely different than it did during your medicine rounds. There were a ton of things that you were looking for before that are usually already ruled out before we see them in our clinics. Clinically, my general approach is to systematically work my way from proximal to distal along the neuraxis. The motor pathway is in red here. It starts with a thought in the brain. An upper motor neuron crosses over and synapses with a lower motor neuron in the anterior horn of the spinal cord. That's over here. So brain, crossover, spinal cord, anterior horn. The axon traverses the ventral root, which is here, plexuses and peripheral nerves, and then eventually gets to a muscle where it causes movement. The whole motor pathway is what we're going to spend our time thinking about in this talk. So let's deepen this discussion. So if someone has weakness, it's really important to approach the differential with a systematic approach like I showed you. I showed you this slide before, but now let's get a bit more detailed about what should be in the back of your brain during the history and physical. FYI, this is mandatory learning for all of my trainees. Weakness can occur when something goes wrong with the brain. This can include trauma, vascular, neoplastic, infectious, and degenerative issues. These will manifest in cranial symptoms, in addition to patterns affecting the limbs based on the location of pathology. Electrodiagnostic testing will not really show much in this case. Weakness can occur when something goes wrong with the spinal cord. This can include trauma, vascular, neoplastic, infectious, and degenerative issues. These will manifest in a neurological level, in addition to patterns affecting the limbs and autonomics based on the location of pathology. Electrodiagnostic testing may be affected if the tests involve the affected level. So if the brain and spinal cord are central nervous system, then everything else is peripheral. This is what we mean when we say neuromuscular. So I just want to clarify what I mean when I'm talking about peripheral neuromuscular conditions, and this is the way I teach my trainees when they're first learning. I organize the conditions based on the proximal to distal site of primary pathology, like I showed you in that anatomical picture. We start most proximally with motor neuron disorders like ALS. Next are the anatomical sites of lesions such as roots, plexuses, or specific nerves. Then polyneuropathies are next, which can be further subdivided as axonal or demyelinating. Neuromuscular junction disorders such as Lambert-Eaton, botulism, and myasthenia gravis. And finally, muscle pathology of different causes. If you feel lost when someone mentions SMA or IBM, I would suggest memorizing this slide as a starting point to alleviate the confusion associated with the laundry list of classifications. So now let's talk about these categories in general clinical terms. How do they present? So starting with motor neuron diseases, they can affect motor neurons in the central and peripheral nervous systems. Both upper and lower motor neuron diseases present with weakness, which leads to atrophy and flaccidity with the lower motor neuron diseases. Reflexes and spasticity accompany the upper motor neuron injuries. Finally, electrodiagnostic testing will only be beneficial with lower motor neuron conditions, which will reveal denervation. So that's just a taste of one of many motor neuron disorders. As we move through the systematic differential, the nerve roots can be affected. The term for this is radiculopathy. It presents with weakness, pain, and altered sensation in the affected myotomes and dermatomes. Proceeding distally to the next structure, physiatrists are uniquely suited to figuring out brachial plexus pathology. This is due to a solid understanding of the anatomy, syndromes, and electrodiagnostic testing. Mononeuropathies are next, and they're particularly satisfying to diagnose and treat, as we use clinical, electrodiagnostic, and now ultrasound modalities to accurately expedite treatment. When we're faced with more than one nerve, peripheral polyneuropathies can be clinically and electrodiagnostically characterized by their pattern of presentation. And during your time as a medical student, you saw ample diabetic and alcoholic neuropathies, which may be more of a stocking glove distribution. But there's also a multifocal mononeuropathy presentation. These can be acquired or hereditary, as you'll likely see on your pediatric rotations. They can also be categorized by the histopathology, primarily affecting the myelin sheath or the axons. Axonal can affect sensory, motor, or both. Demyelination can be subclassified into segmental, like GBS, versus uniform, like Charcot-Marie tooth disease. Finally, the nerves can have a combination of axonal and demyelinating features. The neuromuscular junction is next on our systematic path. We can break these diseases up into sites of pathology. Presynaptic, like Lambert-Eaton and botulism. Synaptic space issues like organophosphate toxicity, and the more commonly encountered postsynaptically mediated myasthenia gravis. Myasthenia gravis diagnosis may come up, but I don't really see these too often, and the treatment is entrenched in neurology's domain. This is characterized by fatigue, proximal weakness, normal sensation, and very characteristic findings on electrodiagnostic testing. Since muscle is the final organ of the motor unit, myopathies have to be considered, especially in the setting of symmetric proximal weakness. Nerve conduction studies will be essentially normal, and EMG will reveal small motor units and spontaneous activity. They're classified by their causes, and the most common cause to come to my clinic is the idiopathic inflammatory myopathies like polymyositis and inclusion body myositis. So now let's look at how we can apply this to a case of a 30-year-old with 1 month of painless wrist drop in the absence of numbness and tingling. Again, our systematic differential is presented for your quick review. So this is where I would open it up to my residents and ask them what they would like to know. So pause and think about what you would ask on history and what you would want to know on the physical exam. So pause. So it's very common to have some kind of mnemonic for remembering about your pain. So character, location, onset, duration, intensity, exacerbating factors, relieving factors, and social issues are what we call clodiers, where I trained. So in this case, there's nothing on clodiers because there's no pain. This patient woke up with it, had a unilateral wrist drop, no other complaints. Past medical history, allergies and meds are none. And social functional, this is a veteran who is now a student. He's independent with ADLs and ambulation, lives alone, and the entire review of systems is negative. So on exam, this is when I would pause again and ask what you guys want to know about. In his case, his neuro exam was essentially normal for cranial nerves, reflexes, manual muscle testing, range of motion, and inspection of the uppers and lowers, except he had slight diminished light touch in his first web space and flaccid weakness in the wrist and finger extensors. So our initial differential, as you remember, was basically systematic. But now we can generate a new differential based on what we think is most likely out of these and like kind of reorganize it. So the first thing I think that everyone is thinking is radial mononeuropathy. or an entrapment neuropathy. He may have a radiculopathy, something going on in the neck. Those are more common. And then, say, a plexopathy, but something in the plexus could be causing this. Polyneuropathy would be next, but it sounds less likely since there's no other limbs involved. So it could be the start of a new polyneuropathy. He doesn't have any pain, and he doesn't have any, he doesn't have any pain. So radiculopathy and polyneuropathy might be a little less likely. Motor neuron disease is definitely something to be considering with painless weakness. But the issue here is that he also has sensory involvement, so it seems less likely. Myopathy, similarly, since there is sensory involvement, less likely. And I'm just not even thinking there's anything intracranial or intraspinal or a neuromuscular junction disorder in this case. So that's my new differential, and that's going to guide what kind of testing I would want. And so here I would say, hey, class, what are all your different options? And you'd get to it eventually. Things that you could do is consultation, imaging, you can do lab testing, and you can do electrodiagnostic testing. So of these, which ones would you want first? Pause again, think about it. And for me, I think nerve conduction studies would be the first thing. I would want to assess his radial nerve. And then EMG, which is putting a needle in there and looking for abnormalities. That would be the next thing on my diagnostic approach. And based on what I see here, I might be doing an MRI of the neck or the brachial plexus or the elbow or wherever I think the problem is based on my nerve conduction studies in EMG. And if it's maybe a peripheral neuropathy, I might be sending them to neurology for lab testing, or I might send to neurosurgery if we find something crazy that, cancer, tumor, infection, fracture that needs surgical addressing. So the options to consider in this case, I think, is the nerve conduction studies, sensory nerves, motor nerves, maybe late responses, maybe repetitive stim, electromyography for sure. And these are all the things that we can do for nerve conduction studies. These are all the things we can do for electromyography. And for this patient, I want a radial sensory and a radial motor. Depending on that, I would then want to assess the other nerves in the same limb just to make sure that motor and sensory nerves are normal throughout and he doesn't have a peripheral polyneuropathy. And then EMG, I would do representing muscles representing the cervical roots and plexus components that I think are involved. So that was kind of a general approach to a clinical case. Now let's get into the weeds. In the last lecture, you saw this slide and we unpacked the dickens out of it. Shocks are delivered to the body for nerve conduction testing. After the nerve is stimulated with this exogenous current, pickup electrodes elsewhere on the body display the electrical activity generated by nerves or muscles. The picture on the screen is called the evoked response. The x-axis measures time and the y-axis measures voltage. Motor nerve conduction studies are the subset of nerve conductions where you pick up the electrical activity over muscle fibers of the muscle belly of the nerve being stimulated. Let me say that again. They're the subset where you pick up the electrical activity over muscle fibers of the muscle belly of the nerve being stimulated. This is different from the sensory nerve action potentials, where we were picking up the signal summation of all the axolemmas underneath the pickup electrodes. Since you may not remember everything we went over before, let me remind you about some things. If you slice a nerve, you'll see that it has a skin around it called epineurium. There are bundles of axons called fascicles surrounded by a sea of connective tissue called perineurium. Finally, there's a matrix around each individual axon within the bundle that is called endoneurium. We also went over the naming classifications of neurons. We also covered the anatomy, physiology, electrophysiology, and action potential propagation of a nerve, of a neuron. I went into detail about the difference between unmyelinated and so-called saltatory propagation. We talked about how the stimulator delivers current and how that evokes an action potential. We also covered how the equipment works. So, how does the stimulator actually stimulate a nerve? Well, you already understand the electrical aspects of the sensory neurons. This is the same in motor neurons up to a point. The new information you need is regarding the neuromuscular junction and the muscle. So these are obviously not present or relevant to the sensory study. I'm going to briefly show you the whole process of a neuromuscular transmission process first, then describe it in detail, then show you this exact same slide again. First, you have a thought about moving in the brain, which sends a signal from your upper motor neuron to your lower motor neuron in the anterior horn. An action potential propagates along the alpha motor neuron's surface, eventually reaching the terminal, which is full of voltage-gated calcium channels. The terminal is embedded in a muscle with primary and secondary clefts to form the neuromuscular junction. Intracellular calcium intracellular calcium from the voltage-gated calcium channels induce vesicles to mobilize and exocytose approximately 10,000 molecules of acetylcholine in each vesicle. Half gets gobbled up by acetylcholinesterase and the rest bind to acetylcholine on the postsynaptic membrane. These are ligand-gated channels that initiate muscle fiber action potential. This slowly propagates along the membrane into the center via T tubules. Intracellular calcium ions attach to troponin, which moves tropomyosin out of the way so that actin and myosin can perform the power stroke. This results in contraction. So we're going to go over that again, don't worry. Regionally, there are upper motor neurons and lower motor neurons. The upper motor neurons sit in the brain and spinal cord and project in tracts that, quite honestly, I've forgotten. They do cross over at some point to meet with lower motor neurons, which sit in the spinal cord. The alpha motor neurons are the ones sitting in the anterior horn cell, which we typically care about. The anterior horn cell is the big cheese of the motor unit. The term motor unit refers to the anterior horn cell, its axonal projection, and all of its associated terminals, junctions, and muscle fibers. Here you see two motor neurons projecting to a muscle belly. The blue one has many neuromuscular junctions with a set of muscle fibers interdigitating between muscle fibers belonging to another motor neuron in red. Incidentally, the motor neuron determines whether the muscle fiber will be oxidative or anaerobic. In 3 dimensions, the neuromuscular junction looks more like a glomerulus. But if you magnify as it interfaces the muscle, you see a primary cleft and many secondary clefts, which increase the surface area. The physiology of membrane potentials and propagation are essentially the same as already discussed with sensory nerves. Here we face the axon terminal, where we also have a voltage-gated calcium channels and acetylcholine vesicles. Here we can see terminals histologically with motor end plates, axons, muscle fibers, and even the spindle in real life. An action potential causes an influx of calcium ions at the nerve terminal, where vesicles filled with acetylcholine are mobilized, docked, and primed to the membrane before exocytosing into the synapse. These vesicles have numerous proteins, which we routinely target in clinic with botulinum toxins. If acetylcholinesterase in the synapse doesn't gobble it up, acetylcholine will bind to receptors in the muscle membrane, initiating a new action potential and muscle contraction. I just love these pictures, so take some time to look at them. For seniors studying repetitive nerve stimulation for the boards, it's important to note that there are 3 different sources of acetylcholine vesicles available to the nerve terminal. Some of it's immediately available at the terminal. There's a larger depot storage that can replenish the immediate store. And finally, there is a surplus storage in the axoplasm. My mentor, Dr. M, compares it to the soldiers at the front lines of a war, the ones at the base, and the rest of us who are available for the draft back home. So, if motor studies involve muscle, we need to talk about muscle. The purpose of muscles is to move and or stabilize bones. So here you see a bone, and the tendon is a non-contractile tissue that attaches the bone to a muscle and transmits force or tension to the bone. The muscle belly is what we see with our eyes, and it has a name like biceps. Each belly is a bundle of bundles called fascicles. The fascicle is a bundle of muscle fibers, each of which is a single multinucleated muscle cell. The cell is packed with these myofibrils, which themselves are comprised of filaments. So let's backtrack to the neuromuscular junction. After the acetylcholine is released by the lower motor neuron into the synapse, it binds to the receptors on the muscle membrane, which open up ion channels to start an action potential along the muscle membrane. The muscle cell is huge. And so how is the depolarization going to transmit from the muscle surface to the inner depth of the cell for contraction to occur? The solution is seen when looking at a muscle cell membrane or sarcolemmal surface, and you'll see many invaginations along the surface. I love this picture, which really makes it clear what these T-tubules look like. Their purpose is to carry the wave of depolarization from the surface into the middle of the cell. They sit next to sacs of sarcoplasmic reticulum, which are full of calcium at the ready to cause contractions. These here are the triads you learned about in histology. So we should have all memorized by now that action potentials propagate at about 50 meters per second along myelinated nerves in the upper limbs. Muscles conduct a lot slower. Muscle membrane conduction velocity is in an order of magnitude slower, and it seems to be a board question every year that the muscle membrane is about 5 meters per second. So returning to the structure, under the microscope we can see these thick and thin filaments repeating. Each is called a sarcomere and is the muscle's histological unit of contraction. If we look at a sarcomere, the way muscle shortens is that the thin filaments interdigitate and slide along the thick filaments. This is called the sliding filament theory. For this to happen, when calcium attaches to troponin, it moves tropomyosin out of the way so that myosin can interact with actin. This is called a power stroke, and obviously it's going to require ATP energy. So that was probably the fastest summary possible of what you learned in biology and histology. So now let's review that whole process again. First, you have a thought about moving in the brain, which sends a signal from your upper motor neuron to your lower motor neuron in the anterior horn. An action potential propagates along the alpha motor neuron surface, eventually reaching the terminal, which is full of voltage-gated calcium channels. This terminal is embedded in a muscle with primary and secondary clefts to form the neuromuscular junction. Intracellular calcium from the voltage-gated calcium channels induce vesicles to mobilize and exocytose approximately 10,000 molecules of acetylcholine each. Those are called quanta. Half gets gobbled up by acetylcholinesterase and the rest bind to the acetylcholine receptors on the postsynaptic membrane. These are ligand-gated channels that initiate a muscle fiber action potential. This slowly propagates along the membrane into the center of the muscle via the T-tubules. Intracellular calcium ions attach to troponin, which moves tropomyosin out of the way so that actin and myosin can perform the power stroke. This results in contraction. So that is a very fast review of muscle physiology. Hopefully you've got it, and also of neuromuscular physiology. So we've covered alpha motor neurons, but beta and gamma are important too. They're involved in the muscle spindle, which I'm going to explain to you. This is a complete digression, but I love teaching it. You'll hear a lot about the spindle if you talk to osteopaths or deal with spasticity. It's an encapsulated organ that lies in parallel with the rest of the muscle belly and sends information about the length of the muscle back to the central nervous system. Fibers within the spindle are called intrafusal. Anything outside it, the skeletal muscle you usually think about, is called extrafusal. So there are afferents sending signals back to the central nervous system about how long the muscle is at that time, and there are efferents to the spindle stimulating contractile elements within. The intrafusal efferents are motor neurons, not the alpha motor neurons you see going to the skeletal muscle. These are called gamma motor neurons. They're stimulating nuclear bag fibers and chain fibers, and these contract. I'm going to tell you how this works now. The spindle is constantly sending signals up to the central nervous system as seen in the top picture, and you can see that vertical line suggesting like it's going deet, 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 deet. That's being sent back to the central nervous system. When the alpha motor neuron stimulates the skeletal muscle to contract, the belly shortens. The central nervous system gets signals that the spindle is now slackened. So the gamma motor neuron stimulates the contractile part of the spindle to shorten as well, removing the slack on it. And then it comes back to deet, 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 deet. And that's how the spindle works. People confuse the spindle with the Golgi tendon organ, the GTO. This is an encapsulated Golgi tendon organ which sits within the tendon detecting tension developed by muscle contraction but not stretch or length. Magnified with tension, the yellow helices over there that you see are collagen, and they're pinching the interwoven red 1B afferent axon. This signals for relaxation when sensing overloading of the muscle. And this is what's going to make you cause failure when you're maxing out on your weight training. One more topic is tendons. We already talked about muscles in depth, and we briefly mentioned tendon before. It's specific collagenous tissue that attaches the muscle to bone. This family medicine paper shows healthy tendon with the collagen all pristine and organized. Within activity, you get degeneration or tendinosis. The term tendinitis refers to acute inflammation, which this does not represent. Now that we've covered muscles, let's review what the machine is doing. The concept of the machine as it relates to the motor studies is exactly the same as it was for sensory in the last lecture. So the stimulator delivers current to the nerve, and the action potential propagates to the hand. The 3 electrodes pick up the activity and feed it into a differential amplifier, which amplifies the differences between the different electrodes. The resultant signal is then filtered and converted into computer ones and zeros so it can be stored, manipulated, and measured. This can then be heard through a speaker, and the evoked response can then be viewed on a display. So now we've unpacked this. Motor nerve conduction studies are performed somewhat similarly to sensory studies. Here we attach an active surface electrode over the motor point and a reference somewhere nearby to cancel out noise. The motor point is essentially just the mid portion of the muscle belly where the neuromuscular junctions are purported to being located. This is typically done over the hand or foot, but can be done anywhere including more proximal limbs, face, or trunk. After delivering an exogenous current via surface electrodes to the stimulator wand, through the stimulator wand, the action potentials will propagate down the nerve to the neuromuscular junction. The evoked response is called a compound muscle action potential. This is the summated electrical activity from the synchronously depolarized sarcolemmas under the electrode from the proximally depolarized nerve. Here we see that surface electrode directly over the motor point. It's picking up negative extracellular voltages, which propagate towards the tendons and away from the electrodes. This results in the up and then down going waveform. Unlike the SNAP, which assesses nerve action potentials, CMAPs are measuring muscle action potentials. 2 points relevant to muscle being the middleman. First, the CMAP is an indirect assessment of motor nerves. The second is that there is a magnification effect. One axon gets amplified by all the muscle fibers it innervates. So this makes CMAPs less technically challenging to deal with and a little easier to get. I added some more thoughts per Lambert. Latency, time expressed in milliseconds between the moment of nerve stimulation and the onset of the resulting waveform. Motor latencies reflect time required for passage of impulses along the motor nerves, the neuromuscular transmission, and initiation of muscle action potential. So, unlike the SNAP where you stim and then there's propagation of an action potential and you pick up right away, here we stim, there's propagation of an action potential, but then there's a neuromuscular junction in between, and then the muscles are depolarizing, and those are depolarizing at a much slower speed, 5 meters per second. So the latency that you get does not reflect nerve transmission only. It's got a whole bunch of other things in there. So there are all sorts of ways to mess up your latency calculations. If you crank up the current, you'll effectively be stimulating closer to the pickup electrode. Picture the difference in splash between a pebble versus a rock in a pond. Similarly, if I stim at X centimeters but use a lot of current, the effective stim site is spread out from there like the splash of the rock. So instead of right here, it'll be kind of spread. So if I accidentally switch my cathode and anode, that will give me a artificially prolonged latency. And fortunately, unlike sensory, stim artifact doesn't affect CMAPs nearly as much as it does obtaining SNAPs. Your machine probably has a knob labeled gain. When you crank this up, it magnifies the waveform. That zooming in effect on the screen is actually called sensitivity, but the machines all say gain. Anyway, with a CMAP, if you crank up enough, you can see the onset latency a little better, and you'll probably be able to move it over to the left a bit more. This is not seen with sensories. Typically, motor nerves are stimulated to points along the course to calculate a conduction velocity along the nerve segments between the two stimulation points. The surface distance between the two stimulating points divided by the difference in their latencies gives you velocity. It's expressed in meters per second. It's about 50 meters per second normally in the upper limbs. Wilborn believes they are the most overrated of all nerve conduction study components. Now, I would have gotten a chief resident or a senior resident who's done EMGs to read this question out loud. Basically, this is seeing if you understood what I said about motor stimulation versus sensory stimulation. Amplitude is the height of the evoked response expressed in millivolts or microvolts as measured from baseline to negative peak for CMAPs. It's a semi-quantitative measure of the number of axons conducting impulses from the stimulating to the recording point. Amplitudes are affected by how synchronous the axonal and muscle membranes are conducting, how efficient the neuromuscular transmission is, the number of muscle fibers, and the distance from muscle to pick up electrode. Per Wilborn, they are the only component to have a direct relationship to clinical symptoms. A response which is 50% or less than that obtained in the other side is considered abnormal regardless of how it compares to laboratory values. How much you stim can also affect the size of the CMAP. Remember that stimulation intensity is defined by the effect it has on the evoked response. If you press the button and get a waveform, it's sub-threshold. You keep increasing until you get something, at which time it's called threshold stimulation. And then you'll keep increasing thereafter the current until it doesn't have any more effect on the waveform. That point is called maximal stimulation, and everything between threshold and maximal is just called submaximal stimulation. Finally, we juice it up an extra 20% beyond maximal to ensure that all the axons have been stimulated, and that's called supramaximal stimulation. That is what we hope to attain in most studies. Stability of the waveform refers to how identical one waveform is to the one prior when stimulating at the same spot on the same nerve. Generally, during the study, we'll say that it's a reproducible waveform, and that also refers to its stability. Meaning, if you get one waveform and it was really from artifact, or you just did something wrong and you don't get it the second time, ensuring reproducibility means that you won't take an erroneous waveform. Electrode placement is also crucial. By placing the active electrode, or E1, on the muscle's motor point and the reference electrode, E2, on an electrically inactive region, the magnitude of the response is maximized. Placing both over the same muscle results in a marked drop in CMAP amplitude, shortening of minimal peak latency, but no effect on onset latency. This is demonstrated here. Amplitude can also be affected by temporal dispersion and phase cancellation. Essentially, there are a range of conduction velocities between the fastest and slowest fibers. This difference becomes easier to see over longer distances, causing the amplitude to decrease with proximal stimulations. This is just like in that runner analogy I showed before, and because there is overlap between upgoing and downgoing portions of the waveforms, amplitude will be decreased when these cancel each other out. So the bottom line is amplitude can decrease a bit because of this up to a point. Most people will not attribute more than about 20 to 30% of a drop in amplitude to temporal dispersion or phase cancellation. If you do see more than 20 to 30%, you have to attribute it to something else. So if that's the case, meaning that temporal dispersion and phase cancellation decrease amplitude with distance, then you should never see a larger amplitude with proximal stimulation. What could be the 3 reasons that you do see that? This is one of my rules. So all my residents have to memorize this. If you get a larger amplitude proximally, you've either not stimulated enough distally, so submaximal stimulation distally. You've stimulated too much, overstimulated proximally, and now you're getting co-stimulation of another nerve. Or there's some kind of anomalous innervation that would explain it. But otherwise, because of temporal dispersion and phase cancellation, you really shouldn't get a larger amplitude proximally, other than for these three reasons. Phases are defined as the number of baseline crossings plus 1. But visually, the shaded area there is the first phase of the CMAP, and it's got 2 phases. One thing you'll notice is all the CMAPs are biphasic with an initially upgoing deflection. If you do see an initial positive deflection or downgoing deflection, that probably means your technique is subpar. And here are some tips for troubleshooting, as well as a diagram showing you why that's happening. Another reason you may see changing number of phases or instability is that you're overstimulating. So inadvertent stimulation of nearby nerves results in misinterpretable changes in waveform morphology. Look for an initial positive deflection or a sudden change in morphology as you're increasing. These could be, indications that you're overstimulating. Duration is the time of the negative phase in milliseconds. We don't really measure this formally too much. It plays more into area. It mainly reflects the relative conduction rates of the impulses as they travel along the various axons between the stimulating and recording points. As duration becomes prolonged, amplitude decreases. Area is a function of both the amplitude and duration of the evoked response measured in milliseconds. It's more accurate. It more accurately reflects the number of axons being activated than amplitude does. Alterations in area can be presumed to be present whenever there are significant changes in amplitude without concomitant changes in duration. We talked extensively about temporal dispersion and phase cancellation in the first part, and I am repeating myself here. Although it applies to motor studies, the effect is not as pronounced as with sensories. This is because the difference between the fastest and slowest fibers is not as pronounced as with sensory axons. So I often tell my residents, if you see a drop of greater than 20 or 30% along the nerve, you have to look for some other cause of the amplitude drop beyond dispersion and phase cancellation. The performance of nerve conduction studies is deceptively simple after you get the hang of them. Obtaining reliable results means being familiar with a myriad of potential pitfalls and technical, procedural, and interpretive in nature issues, and these will present a formidable barrier to accuracy, reproducibility, and therefore clinically reliable studies. Standardization is vital of the machine, physiologic factors, patient characteristics, and procedures employed. You have to obtain reliable laboratory normal values using a standardized approach, normative data task forces. Major sources of error are shown in box 1 here from Dr. Wilborn's articles. Every lab must have its own normal values. Unilateral lesions are best compared to results obtained from the same nerve conduction studies performed on the other side, on the contralateral uninvolved limb. These side-by-side comparisons are mandatory whenever an unfamiliar study is being performed, for which your lab values are not available. Concerning amplitudes, a response which is 50% or less than that obtained in the corresponding limb is considered abnormal, regardless of how it compares to lab values. This is a very conservative number, but computer simulations have validated it with regard to conduction block. So let's return to our case, and now perhaps we can think of which SNAPs, CMAPs, and other studies we want to perform. And this is when I would have you tell me if you have any changes to make. So let's really get into the details of this study. You'll notice we have bilateral radial motor and sensory studies shown along with their waveforms. We also see bilateral median sensory studies. Here's how I would interpret it. First, let's focus on the motor responses. If we compare the left 1.8 millivolts to the right 4.0 millivolts radial motor study, we see greater than 50% amplitude difference side to side. This is significant if all technical pitfalls and factors were addressed. It either suggests that there's a conduction block distal to the most distal stimulation site, or more likely there's an axonal issue somewhere along the left radial nerve, and both Wallerian degeneration has already occurred and collateral sprouting has not occurred enough to normalize the amplitude. Next thing I want you to notice is that there is a 50% drop from the elbow stimulation site to the axilla stim site from 1.8 to 0.8 millivolts. If this was a technically sound study, then that would be considered a significant drop in amplitude along that nerve. This suggests that there is a conduction block between these two sites. This can either be due to a demyelinating lesion or partial axonal lesion that has not yet undergone Wallerian degeneration, such as within the first 5 days after an injury. Briefly, there is some mild slowing at the wrists compared to the distal segments, and some people would just ignore this, while others might follow it with combined sensory index. For now, let's just call the medians normal. The radial sensories, though, they do demonstrate a significant side-to-side difference. And so this means both the radial motor and sensory components are displaying similar corroborating evidence of axonal loss versus demyelinating lesion distal to the most distal stem site. I wonder if there's another way to look for axonal loss. That's when the needle EMG will come in. You'll notice that there are abnormalities in radial innervated muscles from the triceps down. There's one exception here, which is that the pronator had some activity. On physical exam, we saw that the veteran had been wearing a very tight wrist brace, whose proximal border was digging into the volar forearm, right where the pronator is located. The veteran did indeed remember some bruising here. So the pronator abnormality was probably a red herring finding explained by direct muscle damage by the brace. So this is my report for that case. This is an abnormal study. There is electrodiagnostic evidence at this time of a radial sensory motor mononeuropathy with demyelinating and axonal features. And then, of course, I explained the pronator there. I would ask you for your thoughts on other differentials at this point, and I encourage you to pause and think about them as well, and what would support or refute the presence of these in addition to the mononeuropathy. So although we've covered the science and technical stuff associated with typical sensory and motor nerve conduction studies, there are many other cool techniques that are worth studying, understanding, and performing. I'll go into the late responses in a bit more detail, but some of these other ones. Sticking a needle into the neck just near the nerve root and using that as a stimulator is a technique I haven't tried, but my mentor has. He said it's quite uncomfortable. I've performed quite a few blink reflexes, and these take some time to set up and interpret. Sympathetic skin responses are a bit easier. I encourage you to look at the theory behind collision techniques. This is where you stimulate in the plexus while stimulating the ulnar nerve at the same time in the periphery, so that you'll only see the median nerve or vice versa. So I think that's really cool. So we move on to the late responses. These are also known as the delayed responses. These are the H reflex, the F wave. So the H reflex is basically the electrophysiologic version of the Achilles reflex. When we tap on the Achilles tendon, if you looked at that electrically, that's the H reflex. It's the gastroc soleus muscle that's usually checked, the tibial nerve. You can do it in the flexor carpi radialis. You can also, it's been shown in the quads, but mainly the H reflex is looked at the gastroc soleus. And if you have a board question, it's going to be soleus. In upper motor neuron diseases, you can also have increased elicitability of it. Basically, there's a loop, an afferent monosynaptic to efferent loop. And it's used with S1 radiculopathies because it's the S1 route that's being traversed. But really, any problem anywhere along the pathway is going to affect your H reflex. So it's maybe a little oversensitive and not very specific. These are some bits of information here for you to elicit the H reflex. More pictures. The nomogram that Dr. Bradham created. The F response is a small motor response that occurs much later than the CMAP. It's usually about 1 to 5% of the motor neurons that are involved. And It's thought to be because of some kind of backfiring that occurs. It's not very well understood. I do have a picture on that. F waves are really something that I use for someone who may have a demyelinating issue like AIDP early on, because it's checking a longer pathway. So maybe you're seeing some of the proximal segments. It's not very specific, and the sensitivity depends on what you're looking for. Here's a little bit about the technique. This lecture really isn't supposed to be about all of this, but I've included all the slides. This is the backfiring that I told you about. This is from Dumitru if you're interested. Evoked potentials are another type of nerve conduction studies. Here you're stimulating something in the periphery and picking up proximally over the neck or skull. These can be auditory, visual, motor, somatosensory, etc. So they are used sometimes for intraoperative monitoring during neurosurgery as well. Beyond nerve conduction studies, needle electromyography is a powerful and prevalent component of electrodiagnostic testing. A needle is inserted through the skin into the muscle. It acts as a microphone within and displays the voltages that it detects. We talked about surface electrodes in our first talk. It's the interface between the equipment and the person. Needle electrodes are inserted into the body's volume conductor. This places it in direct contact with the extracellular fluid, which is an electrolytic solution acting like the electrode cream on surface electrodes. The two major ones you'll come across are the monopolar and the concentric. Monopolar electrodes are essentially a shaft of metal surrounded by a coat of Teflon other than the tip, which is exposed. This ends in a point, and the metal serves as the active, or E1, for the differential amplifier. The recording region is rather large and spherical compared with concentric electrodes, which have a layer of metal around the layer of Teflon. This serves as the E2 or reference electrode, and it's a bit easier on the examiner if they don't want to have to use a separate cable for their E2 like you do with the monopolar electrode. The tip is beveled, as you can see here, making the recording region a bit smaller and hemispherical. So it has a directionality to it. Some say the concentric is more painful or causes more bleeding because of the bevel. A debate continues as to which to use, as neither is the ideal needle. In the final analysis, personal preference and training biases seem to be the dominant factors in determining the type of electrode people use in clinical practice. Just avoid mixing, matching parameters between needle types and labs. Also, develop reference data for both types of electrodes. You may encounter other needle electrodes, such as the single fiber electrode, a modified standard concentric needle electrode where the central wire exits approximately 4 millimeters proximal and opposite the beveled tip through a side port in the cannula, instead of extending along the length of the cannula to the beveled tip. In conjunction with an elevated low-frequency filter setting, the diameter of the recording surface, which is 25 microns, it's small enough to record one single muscle fiber. Yeah, that's why it's called single fiber electrode. This ability to measure separate muscle fiber action potentials from the same motor unit can be useful in the setting of neuromuscular junction disorders. Then there's the bipolar concentric, which includes E1 and E2 and ground all in the same needle. It's big, it's expensive, and it's painful. And then there's subdermal scalp electrodes, which are used for intraoperative monitoring. When we stick a needle into the muscle, what are we seeing? These pictures show you what's really going on. Here's a motor neuron with all of its junctions and muscle fibers that it innervates. The spherical recording region at the tip of the needle is picking up all of these single muscle fiber action potentials and summing them up to give you this motor unit action potential. In big muscles, you're only seeing the portion of the motor unit that's near the tip. The resultant MUAP, or motor unit action potential, has amplitude, duration, turns, and phases, which we analyze and interpret for clinical reasons. So motor units are voluntary activity, and really just one type of finding when the needle is inserted. And we can look at all those different parameters. So the parameters that I showed you will be affected when there's a nerve injury. For example, the number of turns and phases will increase. The duration and the amplitude will eventually increase. The stability that we talked about might be different as the collateral sprouts are initially immature. And there might be differences in terms of how many motor units are recruited. After an axon is damaged and Wallerian degeneration has occurred, the muscle fibers are now orphaned that belong to that axon. So the neighboring axons will extend collateral sprouts, neurites, that will reach the orphaned muscle cells and start to innervate them as well. And so when this happens, you start to see asynchronous firing between the newly adopted muscle fibers, and the original muscle fibers from the motor unit. And then slowly over time, they become more synchronous, and they give you larger motor unit action potentials as a result. In addition to voluntary activity, we also document insertional activity, which is anything that happens when we move the needle. There's three things that can be documented. One is normal insertional activity, which will have a duration of less than 300 milliseconds. Increased insertional activity, which is greater than 300 milliseconds, but not sustained. And decreased, usually that's when the needle is not in a muscle and you're actually in some other kind of tissue. And finally, there's spontaneous activity. This is seen if the patient is relaxed and we're not moving the needle. It's the fun pattern recognition part of needle EMG, like recognizing atrial fibrillation or VTAC on an EKG. You'll spend a lot of time staring at the screen for this stuff. And you'll be distracted by various artifacts that will fool you along the way. It's probably important to just point out that there are filters on the equipment that you can use to try and pull out the 60 cycle interference that we get from the wall circuits. But when you use that filter, you're also going to have a change in your waveform. This was supposed to be a video showing you what that sine wave looks like. This slide shows what we call root screens. You're not supposed to call it that, but that's what everyone calls it. Basically, these are muscles that are chosen for needle examination that represent different myotomes, but if there's a muscle from a similar myotome, then it's innervated by a different nerve. So for example, here you see deltoid is innervated by C5-6, but so is biceps. So if you had an abnormality in both of them, then it's more likely that this is coming from a C5 or C6 problem or maybe upper trunk, but definitely not coming from a single peripheral nerve because they're innervated by axillary and musculocutaneous. So that's kind of the thinking that goes into picking the muscles. When a motor unit action potential is firing over and over again, sometimes it's nice to be able to freeze that, put it on the screen, and then when the next time it fires, you see it in exactly the same place. You can look for changes from one iteration to another, looking at its stability. The technique that is used, or the technology that's used for this, is called trigger and delay, and I find it very useful for motor unit action potential analysis. I would hesitate to stick a needle in someone in certain situations. I'm not going to go into detail about it, but I've included a link here to the AANEM practice FAQ, and your assignment is to go look at that and see what they have to say about doing nerve conductions and electromyography in situations where maybe someone is pregnant, someone has a prosthetic limb, or they have a bleeding problem. Probably a good thing for you to know. So that's it. It's a lot. If I were a resident trying to learn electrodiagnosis, I would look at all of these slides I've put together for you from parts 1 and 2 again, and try to do some memorizing. I'll admit, when you first see these presentations, it's going to seem like it's all over the place, but a lot of thought went into the sequence of the slides and topics. rather than telling you all of the neurophysiology, then all of the instrumentation, then et cetera, by topic, I tried to create a story here with all of that info. It's not easy. No one said it would be, but I'm hoping that you've enjoyed knowing you can access it all here whenever you want. I want to thank Dr. Che M, my mentor, who taught me a lot of this stuff. And then I also have to admit I stole a lot of the images from Dr. Dumitru's textbook, which I strongly recommend for those interested in the topic. I've also included some extra slides from other presentations on anatomy and clinical stuff in the next slides. You can go through these and freeze the slides